Obesity and osteoarthritis, they go hand in hand. When you're obese, your osteoarthritis gets worse. And when you have osteoarthritis, you're not moving. And when you don't move, you are going to gain all the weight which you don't want to. I'm Dr. Nandini Sunkiredi. I'm board certified in lifestyle, obesity, and family medicine. I have an internationally recognized orthopedician here. He's none other than Dr. Guru Reddy, and he doesn't need any introduction. He is world famous orthopedician and he does a lot of knee surgeries, a record number of knee surgeries. Thank you so much, Dr. Guru Reddy, for joining here.
Thank you.
Yeah, you don't need any introduction. Everybody knows you. So I am doing this session about osteoarthritis and how it can impact obesity and how obesity can make it worse. So we all know that it's catch-22 pretty much. So can you tell us how common is this osteoarthritis in your practice?
Osteoarthritis, I would say 50% of the people will have it after the 50. It's easier to remember. After 60, it becomes more than that. Around after 60, I'll say 60% of the people will have arthritis in different grades and different intensities. Not all of them will have symptoms. Some of them will have symptoms right from the age of 45, 50, especially women who are obese. And some people, they just carry on without symptoms except some mild ache and discomfort until the age of 65. So it all depends on the expression of the symptoms, what time they come, and how deep they come. There are two types of expression of osteoarthritis. One is right from the day one, you know that you are getting arthritis in the knee joint. That means they keep on bothering you in the form of morning stiffness or the pain, swellings, and all that. It goes on for a decade. And second expression is also there. That is means you just won't get any feeling except one fine morning. You will get a severe pain and swelling, and you go to the doctor, and the doctor takes an X-ray and says you are in stage 3. A lot of people get surprised. So, no, sir, I didn't have a symptom at all. I just twisted my leg on the steps. How could it be stage 3? But that is a different expression. So that's what it is. Yeah. So almost, I would say, after 50 years, 50% of the people will have an arthritis. Women more than men.
Right. What are the risk factors you see commonly for osteoarthritis?
Yeah, the risk, I won't say call risk factor like cardiac, what we can call them as a predisposing factors. Obesity. The osteoarthritis is mainly dual factor. One is age, second is obesity. And so obesity is the major predisposing factor. And in addition to that, if you have any injury to the joint as a sports and or as a road traffic accident, then if the cartilage gets beaten or any intra-articular fractures, what does that mean is fractures involving the joint. If that happens, the soft cartilage becomes dried and you will get arthritis very early age than the late. And of course, there is another kettle of fish that is called rheumatoid arthritis, which is an autoimmune disorder, as you all know that. So I would just put a very simplistic way of differentiation between osteoarthritis and rheumatoid arthritis. Osteoarthritis is the majority of the people get because of the aging. That is, all of us will go through that. But rheumatoid arthritis, God decides who will get rheumatoid arthritis, who will get diabetes, who will get hypertension, like that. Rheumatoid arthritis is like almost an autoimmune disorder. What does that mean is your own policemen attack you rather than protecting you, they attack you and they make you suffer for that. So your own cells in the body think that your cartilage in the joint is a foreign body and start attacking the cartilage and the lining of the joint, what we call sine wave. So rheumatoid arthritis comes early. Sometimes juvenile rheumatoid arthritis can come in the age of 18, 19 years. And it's a multi-joint. That means not only the knees and hips, sometimes the wrists, the elbows, the shoulders, all of them will be involved, and fingers will be involved in rheumatoid arthritis. Rheumatoid arthritis has got a different set of management until the last post. The medical management is entirely different because there are disease-modifying drugs, and now recently the biologicals came, So rheumatoid medical treatment is entirely by the rheumatologist, not by an orthopedic surgeon. But when it goes to the last step, that means when the joints are completely worn out, whether it's osteoarthritis or rheumatoid arthritis, the surgical treatment is same. There is a joint replacement.
Right. Yeah, definitely. Like, I mean, osteoarthritis is something which we can definitely prevent by losing weight and by doing good lifestyle modifications for sure. And if surgery is inevitable, what do you think? Like, I mean, what kind of patients will have a better outcome?
Yeah, surgery works well in the present context across all the spectrum of patients, all spectrum of ages. The youngest patient I operated is around 20. The oldest patient I operated is 95. So gone those days where you say that you should be only beyond 60, you should get operated. No. Half of my operating list every day will be filled with people around age 40, 45. I don't know why they are coming early, but they are there, number one. It is not the biological age that counts, it is the arthritis age. That means some people, even at the age of 40, have got a knee joints or stage 4, that is the last stage of arthritis. Then we have to operate them. So the best treatment is the best set of patients are between the age of 60 and 70 and who do not have any major comorbid conditions. That means diabetes, hypertension, and all that. But overall, if you take the cross section of patients who come for surgical management of osteoarthritis, the success is outstanding, almost to the tune of 99% in the whole spectrum of the patients.
Right. And what do you advise? Like, what are the lifestyle changes you advise for patients who want to prevent this
Yeah,
osteoarthritis?
lifestyle changes, as I told before, obesity is the only single preventable predisposing factor, number one. So basically, the less you weigh, the better is the weight on the joint. Suppose if you weigh 70 kgs, your both knees take 35 each. If you are 100 kgs, both knees take 50 kgs each. So number one is prevention of obesity. Number two is keeping your quadriceps muscle very, very strong. So quadriceps is the thigh muscle. Quadriceps, why we call it as? Because there is a conglomeration of the 4 muscles. So that's why we call quadriceps. But that is exactly the thigh. So the thigh muscle or the quadriceps is the key for the knee joint. In simple analogy, I keep telling the patients, if the knee joint is Arjun, the quadriceps is Krishna. So unless Krishna works, Arjun is ineffective. So the more you do exercise for the quadriceps, the more you offload the joint of the knee joint. So that is very important. Second is keeping the quadriceps strong. And third point is avoiding overstressing the knee joint. So for example, squatting, like we sit in the Indian toilets and going up and down the stairs are the 2 major contributor factors to increase the stress on the knee joint. The biomechanically, it is proven that 4 times body weight goes through the knee joint in squatting and in steps. That means, let us say you're 80 kgs. When you go up and down the steps, almost 320 kgs goes through the knee joint. That is biomechanically proven. So a lot of people think that steps are very good. No doubt they are good for the heart and for the lungs, but very bad for the knee joint. So I keep telling the people, do not use the steps, use the escalators, elevators. But if you want to have the exercise, do some other exercise. Brisk walking or cycling, swimming are the good exercise. Likewise, sitting on the Indian toilet or doing yoga in the form of Vajrasana and Padmasana are definitely detrimental to the knee joint. So these 3, number 1 is prevention of the obesity. Number 2 is the increasing the strength of the thigh muscle. Number 3, avoiding overstraining the knee joint. These 3 are main important. Coming to the medicines, there are some medicines called chondroprotectives. That means they protect the cartilage. Till today, there is nothing which will put the new cartilage into the joint. No medical science or no medical tablets are there. A lot of people keep asking me, can we put the new cartilage? That injection does this injection does that, which is a load of rubbish. No injection is there, no capsule is there, which will put the new cartilage into the joint. whatever we use chondroprotectors, they will protect whatever the cartilage is left. So that is the most important point. And some people keep on asking about the stem cells, plasma therapy, PRPs, which is again waste of time, waste of money. Till today, there is no scientific level 1 evidence which is proven that these orthobiologics make any improvement in the arthritis of the joint.
Yeah, thank you so much. Yeah, those are really good points, because a lot of people, they think that yoga is really good, but we have to be very careful about doing these asanas. And yeah, definitely, like steppers are more useful, more common these days, but like you have to be very careful about the steppers as well as a part of exercise. Thanks a lot, Dr. Gurvareddy. Thank you so much. This is all
Thank
very
you.
valuable information, and like, I mean, from a world-renowned orthopedician. So if you like this video, please comment and share it, and please follow me on Facebook and Instagram on Stadia Health MD. Thank you.